Okay. So my talk is on phakic IOLs for presbyopic correction, what I call the elixir of youth. Look at this picture. When I looked at it first, I thought it was father and son. And then I was told that it is the same gentleman taking, the picture was taken in a span of a few months. So why does it look like there has been a gap of at least 2 decades between the two pictures? Simply because of the spectacles. Remove the spectacles and a 40-year-old, a 70-year-old man can look like a 40-year-old man. I didn't want to let out your secrets. So for the very first time, we have the care group coming up with the IPCL, the presbyopic IPCL, but I do hear recently the STAR has also come up with the presbyopic version. So the IPCL was available in 2014, but the newer version came out in 2017, and only very recently, I think as late as 2023, they came up with the presbyopic version. The IPCL per se, whether it is presbyopic or normal, these are the features. It has a central hole which balances the pressure on either side. It also helps in removing the visco after the surgery, which is very, very important. The haptic design is such, it's a plate haptic, and it's got 6 plates, so the stability is much more than the other phakic IOLs. And it does not require peripheral iodectomy because of the central hole. The optical diameter is 6.6 millimeters on a regular phakic IOL, but this can be customized according to your need. And the spherical power varies from -1 to -30. Cylindrical power is available from +0.5 to +10, and now you have the presbyopic range going up from +0.5 to a +4. So this is what the IPCL looks like. As you can see, there are a lot of holes there, and this is one of the lenses with a maximum number of holes, which maintains the pressure on behind the lens and in front of the lens, and that is so very helpful because you don't have a fluctuation of pressure. So this is the design of the presbyopic IPCL. Very honestly, it is simply a trifocal apodized lens. And they call it the triphobic lens because the material is such that it does not have the glistening material, and therefore there is less halo and glare. Basically, it follows the diffractive principle, which means that it's the principle of interference, where if the turfs, if the crests coincide, you have a positive interference. If a crest coincides with a turf, you have a negative interference. And while making the lens, they try to see that we have as much of positive interference as possible. It's like any other diffractive lens. Coming to apodization, basically to apodize something means to reduce the height of the steps, and this causes a progressive shift of the energy towards the distance. So the steps are adjusted in such a way that 40% is diffracted for the distance, 40% is diffracted for the near, and 20% is diffracted in between for the intermediate distance. So you think of 2 apodized diffractive elements. The first one, as you can see, the step height keeps on decreasing and the angulation increases, and you have a bifocal lens apodized for far and near. And in the second one, following the same principle, you have a bifocal apodized for far and intermediate. So what happens if you combine the 2 together? You have a trifocal lens with 2 peaks, which gives you the vision for distance, for intermediate, as well as for near. The criteria here is like any other trifocals, the angle kappa has to be less than 0.5. The pupillary diameter should be at least 2.5 in photooptic condition, and mesopic pupil 7 millimeters. The bullseye diameter of a trifocal presbyopic lens is 1.1 millimeter. So even in extreme photooptic condition, the pupil still behaves like a trifocal lens. The diffractive zone is only up till 3.5 millimeters, and beyond that, it is a simple refractive lens, giving you only distant correction. So the 5 variants are available in all these 5 powers that you can see here, and the rings are between 5 to 9 depending on what your additional power is. They do claim that halo and glares are much less than other trifocal lenses. You cannot get rid of it totally, but however, the design, and as I said, it's a triphobic lens, claims that the halo and glare is less. Patient criteria. Now, the patient, of course, has to be of the presbyopic age group, but up till 45 years of age, if the patient is a plain presbyopic, you treat only one eye. So this is the monofocal treatment. You treat only one eye. Wait, once he reaches 45 years, then you treat the other eye. What happens if the patient is both myopic and presbyopic? In that case, you treat the non-dominant eye with the presbyopic lens. The other eye, you put a simple IPCL, treating him only for the distance. Wait till he reaches 45 years of age and then treat the other eye. Once the patient is of 45 years of age, you put a presbyopic IPCL in both the eyes. If the patient is myopic as well as presbyopic, you undercorrect the myopia, leave him slightly myopic. This enhances the depth of the focus. The workup is just like any other phakic lens. You do the refraction, objective, and subjective. Anterior chamber depth has to be 2.8. Nothing less than that will do. You take the K reading, the topography, intraocular pressure. You do a angle. You check the angle, and the white-to-white measurement is again very, very important because this gives you the size of the lens. These are some of the contraindications, and I think the main contraindication here is under no circumstances are you to put a lens when the anterior chamber depth is less than 2.8. And of course, all the other things. Diabetes mellitus is not a complete contraindication. It's just like any other refractive surgery. So I'm going to show you a little video here on how to put this lens. This is the loading of the lens. I use a butterfly cartridge, and we put in the visco, a little bit of the visco. Okay, I'm going to fast forward this a little. So you lift up the lens. You see the alignment of the lens. In a case of a care group lens, there is a notch in the left-hand side, and there are two holes which are always towards the superior quadrant of the eye. It's very, very important to see that your alignment is right. Put it in such a way that the edges are in the groove. In case a bit of the edge is outside the groove, there's every chance that when you're moving it, it is going to break, because these are very, very thin lenses, very, very fragile lenses. So I take time to see that it sits very well. Close it, you hear a click sound which tells you that it has fitted in quite nicely. Put it into the injector, and then you insert it. I will go, this is the marking that I have done. I don't have any other means, so I do a manual marking. You just have to mark 0, 180 degree, that's all. And then you, let me go to the loading straight away. Okay, so this is when I'm putting the lens in, the loading is done, I'm sorry. So the way to put the lens in is the very simple principle. Push and pause, push and pause. This ensures that you can be sure about the alignment, and at any time you feel that your lens has flipped, because these are very thin lenses, you can always withdraw it. It's a very, very, very simple method and a very easy method. And once the lens is totally out and it is aligned properly, you just go in with the tucker and you ensure that the haptics are below the iris. No, what should I say, rotation is required, because as I said, this is a lens that is customized to the extent that you have to put it only at 0, 180 degrees.
Thank you, Dr. Doel.
Yes.
Ma'am, one question I would like to ask you. I mean, what are the subset of patient where you decide which is better to be the treatment option, RLE or pseudophakic, I mean the presbyopic phakic IOL?
Okay,
How do you decide this?
This is a never-ending debate. As far as I'm concerned, I prefer a presbyopic lens where a myopia is concerned, very high myopia, we get very few patients that come with just presbyopia. Most of the patients who are convinced to go for it are those patients who are having very high myopia along with presbyopia. So in that cases, at least up till the age of 55, I would prefer doing a presbyopic lens. Having said that, there are doctors for whom the cutoff age is 51, and then there are doctors who prefer to do RLE as young as even 39 years of age, even below 45. Okay? But for me, I am not a believer in removing the lens if it is absolutely, untouched, if it's fine. So I would go with a presbyopic lens up till the age of 55.
Is there any bearing of AC depth and the age of the patient?
Is there any?
Any bearing on the decision for the AC depth? I
The
mean,
AC depth, AC depth, see, the AC depth theoretically is 2.8. I would much prefer it to be 3. It's 2.8, but I would much prefer it to be 3. And no, the AC depth does not go down to that extent till 51 or 55 years of age. I have had patients.
Of reduction of AC depth with the age.
With aging, but with aging, because we say, that's what I'm saying, that the cutoff age that we use is around 51 to 55, depending on the surgeon. The company says 55. As I said, most of the surgeons are doing 51. The oldest patient I have had is 52 years of age.
AC depth, ACD should be at least 3. 3 is the mistake. You are safe if you are 3. Ma'am, just wanted to ask you a question. If actually I was doing the flipping, if the folding is, it unfolds upside down, and then said somebody advocated, no, you have to take it out and again push it in. So what is your take on it?
That is the safest way to do. You take it out and take it in. And in my experience, the IPCL is very easy to take out. If you can get your hold on any one of the haptics, give a little tug and it sort of rolls and comes out. I have taken it out even through a 2.8 millimeter incision. Having said that, I have flipped the lens inside the AC in 2 cases. Okay, both my patients live to tell the tale. They are able to see 6:9 even now. But it is a risky procedure. You have the cornea above. You have an absolutely virgin physiological lens below. So flipping it in that little space requires a lot of, I don't know about skill, but it requires a lot of courage, definitely. But I have done it in 2 cases with a lot of visco, and they are fine.
Yeah, that's what I was also doing, but now it's changed.
Now,
You can try
Mitra,
it.
I tell you one thing, if the anterior chamber depth is little more, and then if the IOL is little thinner, and at the base, if you can little fold the lens before flipping it back, if you fold the little lens a little bit, you can flip it easily. Then the conditions are 2. The endothelial count should be good, pretty good, and number 2, the anterior chamber depth should be good, and number 3, you are able to fold the near the base. If you can fold the lens there, it can flip back.
I would also say use two instruments from the opposite directions and at the 2 different, one superiorly of the lens, and one on the absolutely diagonally other side, and push in the opposite directions. If you try with one instrument, these are such thin lenses, they keep coming back. So if you can sort of flip it over, then it's fine.
What is the change of dimension in between this presbyopic and the normal IPCLs?
Change in dimension,
Dimension
as
of the lens. Is there any variation of the thickness and all?
No. It's just like the normal IPCL, except for that the trifocality and all that, and the rings that come in.
Nitin, I'll just answer your question. Just one point in addition to what you were asking, it's an extension of that. What does go down with age is not the ACD. The ACD, of course, comes down, but that's done very minimally. What you should look at is, as she suggested rightly, what you should look at is the angle metrics, because that definitely goes down with age. So once you have decided to do a presbyopic phakic IOL implantation of any make of any company, the angle metrics is a must, because that does go down with age, and it's been proved. It's published in literatures. This is the reason why I keep my cutoff at 50, never beyond 50. I've never done a presbyopic phakic IOL thus far, but if at all I decide to do that, I'll definitely look at the angles and not beyond 50, because after 50 it really gets cramped.
But Anurag, I'll tell you something. I heard this argument of yours in one of the debates that you had, and I looked up the literature. I also spoke to a few people who are doing the thing. I think comfortably they are saying that between 52, 55, especially 51, 52, the angle does not go down to that extent to really cause any sort of a thing.
See,
I think
there are two
beyond
things
that
here.
you start the
There are two
cramming.
things here. One is the preoperative angle measurement, which you must do with angle metrics.
Obviously.
And second is you must have an idea for your make and the product that you've chosen. How much how much reduction does it cause in the angle measurement post-operatively? That you must calculate with your non-presbyopic IPCL implants. When I did that, I found that it reduces the angle, cramps it up significantly. That also was a part of my argument in that debate. So, you know, when you are jumbling up the angles, what they cause is they push the peripheral iris up. That's something, and the people that you are saying are doing it regularly do not have numbers in their favors to come out with anything concrete at the moment. So I'm just saying that maybe at the moment we should safeguard ourselves for not being too aggressive and wait and see the results. Because there are two aspects here. One is the pre-op and second is the post-op. Just a thought.